You know, if you went to a personal trainer and told them, like, you wanted to build massive, powerful biceps,
Okay, great.
and their first instruction was to put your arm in a rigid cast for 6 weeks to let the muscle shrink and atrophy.
You would probably just walk right out of the gym.
Exactly. I mean, you'd think they were crazy.
Right, because it completely violates our most basic intuitive understanding of cause and effect.
Yeah.
You generally don't achieve a physiological goal by subjecting the body to its exact opposite.
But today, for you listening, we are exploring a medical scenario that poses that exact same paradox. Our mission in this deep dive is to answer a highly specific and honestly seemingly contradictory question.
It really is a fascinating one.
Yeah. Can vaginal dilator therapy, which is a treatment designed to stretch and relax tissue, actually be a required prerequisite before undergoing a treatment designed to shrink and tighten that exact same tissue?
It sounds totally backwards, I know.
It does. So we're pulling from a massive stack of sources to figure this out. We've got official FDA safety communications, guidelines from the National Institute for Health and Care Excellence,
Yeah.
clinical physical therapy manuals, and even women's health clinic protocols.
And those sources are vital, right? Because
Yeah.
they prove this isn't just some wacky theoretical thought experiment. This is a very real, very complex clinical pathway.
Right.
By the time we trace the biological mechanisms from muscle tension all the way down to cellular restructuring, this paradox reveals something profound about how integrated and protective the human nervous system really is.
So to even approach this paradox, I feel like we first need to establish what tightening actually entails in modern medicine, because we aren't talking about surgical procedures here, right?
Yeah.
Where a doctor is like cutting and suturing tissue.
No, not at all. We are talking about a completely different technological approach aimed at structural rehabilitation.
Yeah.
The clinical terms you'll see scattered throughout the literature for why people seek these treatments are vaginal relaxation syndrome, or VRS, and genitourinary syndrome of menopause, or GSM.
Let's break those down a bit for the listener. Vaginal relaxation syndrome sounds straightforward enough. We're talking about a feeling of looseness or laxity that typically happens after childbirth. A
Right.
genitourinary syndrome of menopause is, well, it's a bit of a mouthful.
It is, yeah. And it encompasses a much wider range of symptoms. When a person goes through menopause, the profound drop in estrogen causes the mucosal lining of the vagina to thin out.
So it changes the actual tissue structure.
Exactly. It loses its elasticity, its natural lubrication, and its structural support. So people experiencing either VRS or GSM are often dealing with severe dryness, a feeling of structural weakness, and basically a loss of normal function.
And to treat this, the medical community has seen a massive boom in what our sources call energy-based devices, or EBDs.
Yes, the market for these has exploded.
And these generally fall into two categories, right? First, you have radiofrequency devices, which listeners might recognize by brand names like Thermiva or Empower RF. And second, you have fractional CO2 lasers, like the Mona Lisa Touch.
Right, and while they use completely different types of physical energy, radio frequency waves versus fractional light beams, the biological mechanism they are trying to trigger inside the body is essentially identical.
Okay, how does that work?
Well, the practitioner inserts a physical probe into the vaginal canal. This probe then emits energy that penetrates the surface and gently heats the subepithelial layers of the tissue.
Wait, so the treatment is intentionally causing a burn inside a highly sensitive area.
I know, it sounds intense.
It sounds incredibly counterproductive if the goal is to heal and strengthen the tissue.
That is a very natural reaction to hearing this.
Yeah.
But the key word here is controlled thermal injury. The device is calibrated to bring the tissue to a very specific temperature threshold,
Like, how hot are we talking?
usually around 40 to 45 degrees Celsius. It is just enough heat to signal the body's natural emergency repair systems without causing catastrophic damage.
Oh, I see.
Yeah, and when the tissue reaches that temperature, it stimulates cells called fibroblasts.
And fibroblasts are essentially the construction workers of the cellular world.
That is a great way to look at it. Those fibroblasts wake up and immediately start synthesizing new collagen and elastin fibers.
Okay.
This whole process is called neocollagenesis. Alongside that, the heat triggers neovascularization, which is the formation of entirely new microscopic blood vessels to supply the area.
Okay, so it's somewhat like aerating a lawn.
Oh, I like that analogy.
Yeah, like if you have a patch of grass that's struggling, you take a machine and punch a bunch of holes deep into the dirt. It looks destructive, right?
Yeah.
And you are technically causing micro injuries to the soil and the roots. But that trauma forces the root system to work harder, pulling in more oxygen and nutrients so that the glass grows back thicker, greener, and much healthier. Except here, I mean, we're talking about restructuring human collagen networks.
That analogy captures the mechanism perfectly. Over the course of a few weeks or months, this restructuring results in vaginal walls that are fundamentally thicker, firmer, and tighter. Plus, you get vastly improved natural lubrication because of those new blood
That
vessels.
makes total sense.
But, and this is crucial for the sake of our paradox today, there is a critical physical limitation to this technology.
Yeah.
To achieve this neocollagenesis, the tissue has to be physically capable of receiving the treatment.
Right, the probe actually has to go in.
Exactly. The probe has to be inserted, and for many of these devices, it needs to be rotated a full 360 degrees inside the canal to distribute that heat evenly.
So the machine literally can't do its job if it can't physically access the space.
Precisely.
Which is the perfect pivot to the exact opposite side of the spectrum. Let's look at the science of stretching and relaxation, specifically dilator therapy, and why a patient might actually need it.
Right, so while those energy devices treat laxity, dilator therapy is deployed to treat conditions characterized by severe tension, restriction, or narrowing.
Okay.
Our clinical manuals highlight several conditions, starting with vaginismus. This involves a highly distressing cycle where fear of pain causes involuntary muscle spasms in the pelvic floor.
And that makes any sort of penetration incredibly painful or just physically impossible.
Exactly. Then there's dyspareunia, which is a broader clinical umbrella term for painful sex. And finally, hypertonic pelvic floor.
Let's parse that term, hypertonic. I know hyper means too much or overactive, but what does tonic mean in the context of a muscle?
Good question. Tonic refers to resting muscle tone. Even when you are completely relaxed, your muscles maintain a baseline level of tension to keep your posture and hold your internal organs in place.
Like keeping everything supported.
Right. But in a hypertonic pelvic floor, that baseline tension is dialed up to a 10. The muscles are locked in a constant, unyielding state of contraction.
So if I were to walk around all day with my shoulders constantly shrugged up to my ears, eventually they're going to ache and burn. Is that basically what's happening internally?
The physical mechanics are identical,
Yeah.
yes. And the consequence of that constant tension is a severe restriction of blood flow to the pelvic region.
Oh, wow.
Yeah, when blood can't circulate properly, oxygen can't get into the muscle tissue. And waste products like metabolites, such as lactic acid, they can't get flushed out.
Right, they just build up.
Exactly. This buildup of toxic metabolites and the starvation of oxygen results in something called ischemia.
So the tissue is literally suffocating from a lack of oxygen because it's squeezing its own blood supply shut.
That's exactly it.
That completely explains the intense burning pain associated with these conditions.
It does. And the primary clinical treatment for this agonizing cycle is vaginal dilator therapy. Our physical therapy sources, including those from Memorial Sloan Kettering, describe these as smooth, cylindrical devices.
And they come in different sizes, right?
Yes, sets of graduated sizes. Starting from roughly the diameter of a pinky finger and scaling up, you'll find them made of soft, flexible silicone. But surprisingly, many clinical pelvic floor physical therapists actually strongly prefer firm, rigid plastic.
That seems totally counterintuitive. If someone is already in pain from muscle spasms, why would a practitioner choose a hard plastic cylinder over something soft and accommodating?
I know it sounds harsh, but the rigid structure is actually the therapeutic mechanism.
Really?
Yeah. When a muscle is hypertonic, it develops specific trigger points. These are tight bands of tissue that need targeted pressure to release. A soft silicone dilator might just squish or bend around those tight bands.
Ah, so it doesn't actually address the knot.
Exactly. A firm plastic dilator provides a solid, unyielding surface that the muscle can stretch against. It provides the necessary counterpressure to manually release those trigger points.
Okay, that makes a lot of sense. The sources are also very clear that this is a highly active therapy. It's not like the patient just inserts the device and sits there reading a book, hoping the tissue stretches out like a tight pair of shoes.
Far from it. The goal isn't just mechanical stretching. It is fundamentally about retraining the central nervous system.
How so?
Well, when a patient engages in dilator therapy, they are actively practicing diaphragmatic breathing.
Wait, how does breathing affect the pelvic floor? They seem completely disconnected.
Think of your torso as a canister.
Okay.
The diaphragm is the lid, and the pelvic floor is the base. They move together like a synchronized piston. When you take a deep belly breath, the diaphragm drops down, pushing your internal organs downward.
Oh, I see where this is going.
Yeah. To accommodate that pressure, the pelvic floor must physically lengthen and drop as well. Therapists use this physiological link.
So by combining deep diaphragmatic breathing with the physical presence of the dilator, they're working together.
Exactly. The patient uses that biofeedback to consciously map and release those hidden clenched muscles.
Some of the clinics mentioned in our sources even incorporate 10NS machines into this routine transcutaneous electrical nerve stimulation.
Yes, tendonets can be very effective.
I've actually used one of those for a lower back injury. They're those little sticky pads that deliver a mild electric buzz. But how does shocking the pelvic floor help it relax?
It's based on something called the gate control theory of pain.
Okay.
Essentially, the nerves that carry a non-painful sensory signal, like a buzzing or vibrating electrical current, travel faster to the brain than the nerves carrying the sharp burning pain signals of the muscle spasm.
Oh, that's clever.
Right. The buzzing effectively closes the gate at the spinal cord, blocking the pain signals from reaching the brain. This calms the nervous system down enough to allow the muscles to realize that the touch of the dilator is safe. It breaks the fear tension cycle.
Okay, let's unpack this. We have two completely distinct medical protocols here. On one side, active dilator therapy using breathing, counter pressure, and nerve stimulation to retrain the muscles to let go, widen, and relax.
Right.
On the other side, radiofrequency probes delivering thermal injuries to intentionally shrink, tighten, and firm up the tissue.
Yes.
Why on earth would a doctor ever prescribe both, like specifically stretching the tissue right before trying to tighten it?
This brings us to the core of the paradox, and it reveals that these treatments aren't adversaries at all. In three very specific medical scenarios, one is the absolute non-negotiable prerequisite for the other.
The first scenario seems to come right back to the physical requirements of the laser and radiofrequency devices. We established that the probe has to get inside the canal and move around.
Exactly. And if a patient has severe vaginismus or a hypertonic pelvic floor, their nervous system will reflexively spasm at the slightest touch.
So they literally just can't do it.
No, they physically cannot tolerate the insertion of the tightening probe.
It's like trying to perfectly tailor a custom suit for someone while they are aggressively flexing, flailing, and tensing every muscle in their body.
That is a brilliant way to visualize it.
You can't possibly get an accurate measurement, let alone make structural alterations, until you get them to completely relax and reveal their true baseline shape.
Yes. So a physical therapist will initiate a graduated dilator program first, using water-based lubricants, and the clinical guides emphatically state to never use petroleum products like Vaseline
Oh, why is that?
because they can degrade the silicone if they're using silicone dilators, and they cause severe microflora imbalances.
That's a no.
So with the right lubricant, the patient slowly trains their pelvic floor to accept penetration. The dilator therapy is required to create the physical access and nervous system safety necessary for the energy device to even enter the room.
This transitions into a massive diagnostic challenge, which is the second scenario. If you're listening to this and thinking, well, how would someone not know if their muscles are too tight or if their tissue's too loose?
That seems obvious, right?
Yeah, but the sources actually highlight how incredibly similar those two things feel to the patient.
They really do. The Women's Health Clinic FAQ specifically addresses this phenomenon. They point out that vaginal stenosis, which is an abnormal structural narrowing of the canal, can easily be mistaken by the patient for laxity.
Wait, how is that possible? How does narrow feel loose?
It comes down to friction and sensation. A patient might experience discomfort, a lack of natural lubrication, or a strange change in friction during intercourse.
Okay.
And knowing they recently had a baby, or moving through menopause, their mind naturally jumps to the conclusion.
Yeah.
Things must be loose, the structure is failing, I need to book a tightening treatment.
Ah, I see. But when the clinician actually performs an assessment, they find the complete opposite.
Exactly. The pelvic floor is in spasm, or a stricture has formed, and the patient is already far too tight.
And applying a thermal energy device to tissue that is already hypertonic or stenotic would be catastrophic, right?
Oh, absolutely. The heat would exacerbate the inflammation, and the trauma would send the already panicked nervous system into overdrive, basically worsening the spasms.
So they have to fix the tone first.
Right. The clinician must prescribe dilators to resolve the guarding, break the pain cycle, and establish normal tone before they even consider addressing the structural collagen with a laser.
And this entire dynamic takes on life or death stakes when we look at our third scenario, the clinical protocol for pelvic cancer survivors.
Yes, this is perhaps the most vital application of this paradox, Patients who undergo pelvic radiation therapy to treat cervical, endometrial, or colorectal cancers face severe, immediate changes to their tissue architecture.
Because the radiation is so powerful.
Exactly. Radiation damages the DNA of fast-dividing cells. In the pelvic region, this leads to an intense inflammatory response, resulting in severe vaginal stenosis, meaning the canal dramatically shortens and narrows in adhesions.
Let's clarify adhesions. That means the walls of the vagina are literally gluing themselves together with scar tissue as they try to heal from the radiation burns, correct?
That is exactly what happens. It's a very difficult side effect. To combat this, guidelines from institutions like the Royal Berkshire Hospital dictate that these patients must begin dilator therapy a mere 2 to 4 weeks after their radiation concludes.
Wow, that's soon.
Yes, the daily insertion of the dilator mechanically forces the tissue to stay separated, preventing the adhesions from locking the canal shut.
Okay, but let's look at that same cancer survivor maybe a year or two down the line. They've diligently used their dilators to keep the canal physically open.
Right.
However, the radiation, combined with medically induced menopause from their cancer treatment, has left them with severe vaginal atrophy. The tissue is bone dry, fragile, and lacks any elasticity.
Which is incredibly common.
And they want to reclaim their quality of life, so they seek out a fractional CO2 laser to stimulate that neocollagenesis we talked about earlier. They want to rebuild the moisture and the firmness.
And the literature explicitly poses the question, should dilator therapy come before tightening after cancer treatment? The answer is a definitive yes. The radiation-induced stenosis and adhesions must be managed and resolved with mechanical stretching first. You have to establish a healthy, flexible baseline of tissue before you subject that highly vulnerable area to a heat-based device designed to restructure collagen.
Because getting the order of these treatments right isn't just a matter of optimizing results, it's a matter of basic patient safety.
Absolutely.
And our sources do not hold back when detailing the grim realities of what happens when powerful energy devices are used indiscriminately on unprepared tissue.
No, they don't. The FDA actually felt compelled to issue a formal safety communication regarding this.
What did they say?
They warned both patients and healthcare providers that energy-based devices, when used for unapproved cosmetic indications or without a rigorous baseline assessment of the tissue's readiness, carry a high risk of severe adverse events.
Like what?
They specifically cited vaginal burns, irreversible scarring, and the onset of recurring chronic pain.
And the National Institute for Health and Care Excellence, NICE, provided clinical case studies that put a very human face on those FDA warnings. And I have to warn you listening, these cases are genuinely difficult to hear.
They are harrowing, but they're necessary to grasp the gravity of the medical protocols. Case 1 details a 65-year-old postmenopausal breast cancer survivor. She came into a clinic presenting with severe vaginal dryness and, importantly, moderate vaginal stenosis.
So she already had an abnormal narrowing of the canal.
She did. But rather than initiating a dilator program to address the stenosis, the practitioner proceeded directly to a course of 3 laser tightening treatments just to address the dryness.
Oh, no.
Yeah. Shortly after completing her final session, the patient engaged in intercourse and suffered severe vaginal wall lacerations, resulting in heavy traumatic bleeding.
That is awful, and the long-term fallout from skipping the dilator prep was even worse, right?
Sadly, yes. Several months later, she returned for an examination. The thermal energy of the laser had triggered such a massive, chaotic, fibrotic reaction in her already compromised tissue that her vaginal canal had foreshortened to a mere 2.5 centimeters.
Wow.
It was entirely dense with fibrotic scar tissue.
And we see a similar cascading failure in Case 3 of the NICE's guidelines.
Oh.
A 68-year-old woman developed persistent, worsening pelvic pain after undergoing 3 courses of laser therapy.
Right?
When clinicians finally examined her, they found she had developed a thick, crescent-shaped fibrous band of scar tissue right in the middle of her vaginal canal. The laser had quite literally created a partial structural obstruction.
What's fascinating here, well, fascinating in a very grim way, is the ultimate irony of both of these severe case studies.
Yeah.
When these women presented with devastating scar tissue, foreshortened canals, and fibrous obstructions caused by the tightening lasers, what was the medical solution prescribed to fix the damage?
A rigorous, long-term home vaginal dilator program.
Exactly.
If a practitioner skips the vital step of assessing the tissue, ignoring the hypertonicity or the stenosis, the tightening device causes so much immense trauma that the patient ends up needing the exact dilators they should have started with just to rehabilitate the fresh damage.
It is the starkest possible reminder of the foundational principle of medicine, primum non nocere. First, do no harm.
Right.
You cannot force a biological structure to heal or demand that it synthesize new collagen by subjecting it to thermal stress if it lacks the baseline flexibility, the blood flow, and the nervous system regulation to actually process that stress safely.
We started this deep dive looking at what seemed like an absurd contradiction. Using a plastic cylinder to stretch a tissue right before using a high-tech laser to tighten it.
Yeah, quite the paradox.
But what this journey actually reveals is a profound respect for the complexity of the human body as an integrated system.
Because the muscles, the nervous system, the blood flow, and the connective tissue are constantly communicating. You can't just apply a quick fix machine and demand results.
Yeah, that makes total sense now.
Whether you are helping a patient overcome the fear avoidance cycle of vaginismus, or carefully rehabilitating fragile tissue after life-saving pelvic radiation, the foundation of safety and flexibility has to be established first. Dilators establish that communication, allowing the highly advanced energy devices to do their restorative work safely.
Which leaves me with a final lingering thought for you to ponder as we wrap up. We've spent this time exploring how radiofrequency waves and fractional lasers can successfully trigger the body to completely restructure its own collagen networks using just targeted localized heat.
Right.
If our medical technology can so effectively hijack the body's natural healing response to rebuild the specific tissue, what does that mean for the future of treating tissue degradation and aging on a global scale?
It opens up staggering possibilities for longevity and physical rehabilitation.
Could we one day harness these exact same principles, combining nervous system biofeedback to release chronic tension, followed immediately by controlled neocollagenesis to rebuild the underlying structure, to reverse structural aging across the entire body?
It's an incredible thought.
Could this localized thermal technology eventually render invasive cosmetic and structural surgeries completely obsolete? It completely reframes what we think the human body is capable of repairing.
The capacity for regeneration is already built into us. We just have to learn the proper sequence of unlocking it.
Because as we learned today, even if your ultimate goal is to build, to tighten, and to strengthen the structure, sometimes you really do have to learn how to let it stretch and relax first. Thank you for joining us on this deep dive. Stay curious, and we'll see you next time.